All right, well, I think we'll get started. Thank you so much for joining our January pepper rounds today. Our talk is entitled Diagnostic Challenges in Older Adults, Urinary Tract Infections, Asymptomatic Bacteriuria, and Everything in Between. Dr. Sonali Advani is the Associate Professor of Medicine on the Tenure track at Duke University School of Medicine. She's also a K-12 Urologic Scholar, Duke Pepper Center Scholar, and an Implementation Science Fellow at IRI Institute at WashU University, St. Louis. Dr. Advani has over 10 years of experience in healthcare epidemiology research and operations. Her current research focuses on improving the diagnosis of UTIs in older adults, implementation of diagnostic stewardship interventions, and de-prescribing antibiotics for asymptomatic bacteriuria. She's been awarded several federal grants and foundation awards for her UTI-related research. We're excited to have you, and I will let you take it away.
Thank you for the kind introduction, Dr. Bradley, and thank you to all the directors, members of the Pepper Center at Northwestern University, as well as the Pepper Centers in general for funding my work and for all the mentorship. As an aside, I was just filling out our 6-month report, and I wasn't even able to have enough space to fill up how much the Pepper Center has done for me in terms of what are the benefits of the Pepper Center. So I am really grateful for all the collaborations and opportunities that come from being a Pepper Center scholar. The topic for today is a passion of mine. I'm very passionate about diagnosing UTIs in older adults and trying to find age-friendly approaches to both diagnosis and management of UTI. There will be some audience interaction as we go through this, and I understand that we're on Zoom and everyone's cameras are off, but there will be a lot of questions where you can chime in and select A, B, or C options, so that allows us to think and be a part of this. So I'll start with my disclosures. None of these are related to this talk, but I have shown my funding, which includes the Pepper Center funding, which funds some of my work. So the objectives of the talk today are to understand drivers of inappropriate test utilization and overdiagnosis of UTIs in older adults, and to leverage focus group discussions and semi-structured interviews to understand the challenges with diagnosing UTIs in older adults, and then to review some implementation strategies that target specific barriers. So I'll start with a case because it kind of sets the stage of the patients that we are thinking about. So we have a 64-year-old woman with chronic lower back pain who presents to the emergency department with confusion, increased drowsiness, rhinorrhea, and nausea. Notably, review of her gastrointestinal symptoms was negative, but keeping in mind she is a bit confused. She recently stopped taking some medications that were habit-forming, like tramadol and tizanidine. And then on exam, she was a little bit tachycardic. She had a temp of 99.8. Overall, the exam was not remarkable, except for some increased drowsiness and some confusion. Her laboratory results were unremarkable, and the serum WBC count was normal, electrolytes were normal. Her urine analysis showed 9 white cells, trace leukocyte, S-trace, negative nitrites, moderate bacteria, and 5 epithelial cells. So at this stage, what will you do next? Will you order urine culture? Will you empirically treat the patient with ciprofloxacin for 3 days? Or treat them with an oral beta-lactam for cefpodoxim for 3 to 5 days? Or perform a more detailed chart review of previous visits? And so I see the chat is filling up. So feel free to type in your response in the chat. Okay, we have a lot of Ds and 1 A. And this is a real case that was published in JAMA Internal Medicine. And this is what most people would do because we have an audience that is taking care of older adults and is thinking about older adults. But what actually happened was that she was empirically treated with cefpodoxim and discharged. After 4 to 5 days, she had an abrupt onset of watery diarrhea and lower abdominal pain and fever. And this time she was admitted with C. difficile colitis. And then someone performed a review of her nursing home records and found that she had similar symptoms in the past when she stopped her tizanidine and trazodone abruptly. So this happens all the time. And when we're looking at these cases, it's really easy for us to say we should review the nursing home records, but in primary care and the emergency department setting, positive urine analysis findings are very, very important, and they kind of stand out to the clinician. So they're almost always treated. And so I wanted to take a moment here and again, put a question out to the audience is, what do you think was the main barrier here for the ED clinician to kind of pause and not have either ordered a urine culture or even prescribed antibiotics? Which of these factors do you think was the major driver of that decision they made? And I'll pause and wait for you to put it in the chat. Some people say all of the above, but likely EF. Some people say C, E, and F. There's a vote for F as well. And so in interest of time, I'll move forward. What's important is, like what everyone said, is there's probably a combination of factors, and some of it is dependent on where this institution is, or what are their practice patterns. But usually I found a lot of success using the COM-B model to understand the barriers to appropriate culturing and treatment. And the COM-B model is actually using capability, opportunity, and motivation factors that drive behavior. And it splits it up in a way that we can understand what are the barriers. Specifically, when you think about capability, is that, do people even have the knowledge? Do they even know how to treat UTIs, or do they understand what a positive urine analysis parameter means? What is their past training taught them? Opportunity is one of the very interesting ones, because peer pressure or behavior can have an influence and can just be the practice of how we do things here. A lot of time in the ED, they don't have time, or they have an order set that orders urine analysis and urine cultures on all patients that come in with confusion. Or they have an order set that orders a urine culture if the patient has a positive urine analysis. So you don't even have a chance to do the right thing. And motivation is one of the strongest drivers, where belief about consequences, where the ED clinician feels that the risk of sepsis from UTI is much higher in this patient than is the risk of C. difficile colitis. And then the patient, their family, the nurse, what are their expectations in that whole encounter? So we're going to kind of break down each of these, capability, opportunity, and motivation, and see how they drive culturing and treatment behavior. So we'll start with capability. And here again, I have another question for everyone, because this is a patient we see often in the emergency room. So now you are seeing a 70-year-old female in the emergency department for new onset confusion and low-grade fever. Because of this confusion, they cannot express what symptoms they're having, but they do get a urine culture with greater than 100,000 CFU of E. coli. Their urine analysis shows more than 50 WBCs. They have a positive nitrite. How would you classify this condition? And feel free to type in whichever alphabet soup you like in the chat. Yeah, so we're getting some A, some D, some bacteriuria, again, some A, some D. And I think I would have loved to show you the graph, because I did the same poll at Shea, and I did a Twitter poll and an in-person audience poll, and we were spread all across. And that's what the interesting part is here. So I want you to think about, some people think it's A, some people think it's D, some people think it's bacteriuria, and some people need more information, because this is real life. But what do our guidelines tell us? So our guidelines just tell us that there are 3 categories. If a patient has no UTI symptoms and a negative urine culture, they do not have a UTI. If they have no UTI symptoms and a positive urine culture, they have asymptomatic bacteriuria. And if they have clear UTI symptoms, meaning dysuria, urgency, frequency, suprapubic pain or flank pain, and a positive urine culture, they have a UTI. Now, it sounds very straightforward. However, real life is about dealing with patients that don't fall into any of those categories. We see an 80-year-old woman who comes in with a history of worsening urinary incontinence. Urine cultures reveal mixed flora. You have a 30-year-old woman who presents with a 6-day history of worsening dysuria, urgency, frequency, and low-grade fever, but she has negative urine cultures. Then you have a 70-year-old man, like we talked about earlier, comes in with confusion, hypotension, low-grade fever, cannot express symptoms, and has a positive urine culture greater than 100,000 colony-forming units of, say, E. coli. And real-life presentations aren't clear. And so people find it difficult to say, is this ASB or is this UTI? And in order to drill down into this further, we decided to look back at least 3,000 to 4,000 patients from 5 study hospitals. So we did a retrospective chart review, and we had trained abstractors look back at about 3,392 patients from 5 study hospitals over 3 years. We created a red cap survey, and I wanted them to go through every patient that was evaluated with a urine culture. So as long as a urine culture was ordered and they had a urine analysis as well, we would go back and figure out why was the culture ordered, what else was going on with the patient, and was this truly a UTI or not? And eventually, we put together a focus group discussion with multidisciplinary experts, a lot of them from the Pepper Center joined as well, to define the continuum of UTI. And I'll show you a little bit of what I mean by the continuum of UTI. And it was mainly to go over the scenarios that we highlighted here. And it was to see, where do they fit? Do they fit in between some of these scenarios? So like, is there something between not UTI and ASB? And is there something in between ASB and UTI? And is this whole thing just a continuum and not separate entities that we can clear-cut define? And then we compared these new categories to the existing categories defined by IDSA, which is the Infectious Disease Society of America, and AUA, which is the American Urologic Association, that have specific boxes that have been created for these patients. And so we decided in the continuum of UTI, there would be some new categories, specifically starting with LUTS, or lower urinary tract symptom. This is a very common term used in geriatrics and urology, but people in internal medicine or even in infectious disease for that matter, don't use LUTS as often. I have seen several of my colleagues disregard patients that have lower urinary tract symptoms with a negative urine culture, whereas in the urogyn world or the geriatrics world, sometimes these symptoms play a much bigger role than the UTI itself. And some patients could have UTI, but a lot of times these patients have symptoms that require treatment. So we wanted to classify them separately. On the right side, you'll see UTI, which we tried to stick with all the current guidelines where you have lower or upper urinary tract symptoms, but we also said if you had, say, fever and hypotension with no other source, or you had fever and delirium with no other source, then you would be considered to have a UTI. Now, in the middle is a new category that we defined, and this came about from some of the discussions that we had in trying to classify patients that had a positive urine culture and confusion, or if a patient had a positive urine culture and end-stage dementia and could not express symptoms, but had some kind of fever or hypotension, but we don't know what's happening, so we can't disregard the urine culture. So we thought that those patients weren't truly asymptomatic bacteriuria. They were somewhere between ASB and UTI. And we defined this group as bacteriuria of unclear significance. And then we looked back at the 3,392 charts that we had abstracted and had all the symptom data that had been collected by trained abstractors, and said, now let's use our biostatistician to kind of apply these definitions. And when we look at our original guidelines, we found that about 30% did not meet a UTI definition, 20% had ASB, and 20% had UTI. Now, there were a significant number of mixed flora, and I purposely did not classify them here because I feel like mixed flora can be a whole other issue. And then there was low colony count, which I did not classify. But then I went and we applied the newer definitions, and we found that not UTI, actually about a third of those patients had lower urinary tract symptoms. So not UTI broke down into 8.8% LUTS and 21.8% not UTI. And when you look at the patients with ASB or asymptomatic bacteriuria, over 2/3 of them had some kind of constitutional symptom or chronic urologic issue with a positive urine culture, where a frontline clinician would not be able to say for sure if this is ASB or UTI. And again, the goal of this was not to say these patients need treatment. The goal of this was to understand the uncertainty faced by frontline clinicians so that when we talk to them or when we approach them for stewardship interventions, we acknowledge the challenges that they're facing. And so that part of it was just the knowledge or the capability or the skills, which we feel like currently we do not have the skills to manage BUS. But moving on into a second category of the COM-B model, which is motivation, which is another very strong motivator of ordering urine cultures and treating urine cultures. So we did a survey of nurses in our units to understand what drives them to recommend urine culturing. And the reason we did this is nurses actually play a very big role in how they communicate a patient's condition to the clinician, or how they express the urgency of needing a culture. And sometimes they collect the culture and they tell you, I've already collected the culture. And what we found here is capability was not that much of an issue. They actually did have good knowledge about, surprisingly, had very good knowledge about culturing indications because of all the algorithms that we have in place. But they were very worried, which is in the motivation side, that they would be criticized for not reporting a change in status. For example, nurses felt that even though foul-smelling urine was not a symptom of UTI, the fact that if they missed reporting it to the clinician, that they would get in trouble. They also felt that by ordering urine cultures, they were improving care, and they felt like they were doing something about situations. So that was important, and it helped us understand that we need to not just focus on education, but focus on empowering nurses so that they don't feel scared and say things like, I think we should just get a urine culture just in case, or I've already collected a urine culture because I think it's the right thing to do here. And that has helped us communicate with the nurses. They also mentioned they get pushback from clinicians when they question a urine culture order, because they tend to have the algorithms on their like day-to-day rounding boards, and not all clinicians have the algorithms, but they feel scared. So I think it's important to understand how much the nurses influence whether or not the clinician will order and treat that urine culture. And then here's one article that I love, which is by Julia Simzak as well as Jeff Linder, which highlights how much the patient drives antibiotic prescribing. And there's tremendous data about it, but I like the phrase, I never get better without it, or whenever I have this, I always get an antibiotic. And if you don't give them an antibiotic, they say, why did I bother to come in? And so there's a tremendous amount of pressure from patients and their families for us to prescribe antibiotics, which is a strong motivator. So when you think of motivations, there's other motivations, but these are the ones that I found were mostly driving the antibiotic prescribing and urine culturing, because patients will just not be happy if you don't order a culture. And so the last one, which is the most interesting one, is opportunity, because it covers some things that can very easily be tweaked. So one of the important things here is just your peer pressure or practice. So if your group of ED physicians orders cultures, most people will order cultures in patients even without symptoms, or will treat in patients without symptoms. And we'll talk a little bit about this at the end from my interview data. And then EMR or lab related, which if your lab reports urine cultures in a certain way, it influences people to order more cultures. Or if when you order urine analysis, a urine culture shows up first, it is likely that the clinician may opt to get that urine culture as well as urine analysis because of just the order set and the way it's set up. And then lastly, time constraints is people don't have the time to do the right thing and go through a whole symptom checklist. And the biggest barrier is all the information overload, which we order too many tests and then we don't know what to do with our tests. One example of this is from the CBC that is ordered for H&H monitoring because a lot of us have been told that it makes more sense to order a CBC as compared to an H&H. It's cheaper and it's for some reason easier, which is shocking. And that shows an elevated white blood cell count. And then the physician orders a blood culture because they think that there is some kind of infection somewhere and we just haven't picked it up, but we didn't want that WBC anyways. The patient was fine, but now we have information and we need to do something about it. The same thing happened with urine analysis, which people order a urine analysis for renal function monitoring, but it shows 50 white blood cells or 20 white blood cells, or it shows nitrite. And then the physician orders a urine culture because of that pyuria, not because they were suspecting a UTI. And so we now have a test that gives you more information than you need. And we have reflexive thinking, where because of this knee-jerk reaction of seeing high levels of WBC, somebody wants to do something about it rather than ignore it. And so we actually wrote an editorial on this because we thought about the urine analysis a lot and realized that the urine analysis is actually a compilation of multiple different tests that don't need to be together, but it is one of the oldest tests that was developed and probably would not have passed FDA today because of the number of things in a urine analysis that should not be combined together. We actually recommended in this that the urine analysis should be broken up into a UA for inflammation and a UA for metabolic or renal issues. Because when you're monitoring someone's renal function, you do not need information on their inflammatory status or their WBCs or their nitrite. And so that should not be included in the information. And splitting up the UA would be a great way to give people the information that they need. While this is difficult to do on the lab side, it can be done on the reporting side. So when you report the UA, you can actually change how you report it based on the indication for the urine analysis. In reality, this was very tough to do, so we decided to do something a little bit simpler. We decided to start with one thing, and that is suppressing bacteria on urine analysis. We found that our microscopic urine analysis was reporting any bacteria, whether dead or alive, or even anything that was the same size, was being reported, so it wasn't accurate. And in assessing the relationship between bacteria on urine analysis and UTI, we found that it was non-significant and we didn't need to include that. And this is the same patient from 2014. As you can see, her overall urine analysis is bland. She had 5 to 50 bacteria, which could just be urogenital flora. And she was treated with antibiotics. And the same patient came back in 2021 when we have suppressed bacteria. And here, despite having 1+ leukocytes, there were no bacteria. So the patient didn't think that she needed to follow up about this because normally patients will message you if you see bacteria on the UA. She had no symptoms, so we did not treat this patient. And so I'll pause here and try to get some more participation and see which urine analysis do people think are predictive of UTI. And we can start with just the chat again, if you don't mind putting in your UA parameter of choice in the chat. So we have a 7727. Any other takers for? We have a lot of 7s. Everyone here is so good at this. 1 to 4. Okay. This is helpful. And so we'll go to the next slide to discuss this because there's never a straight answer. So we looked in among those 3,392 patients that we had chart review data on symptoms. We looked at which UA parameters would predict UTI. And when you look at sensitivity, what's interesting is as you have more or increasing leukocyte esterase, your sensitivity drops. Same thing with pyuria. So your sensitivity decreases as your levels of pyuria increase. And again, for nitrite, it's very poor. So I'm not sure why we would be using these for sensitivity. And so most of the times what we do is we use them for their negative predictive value. It is helpful because the absence of pyuria is a good indicator of the lack of UTI in a non-neutropenic patient. So that is something that has been used and has been promoted. And it was true here in terms of like, there's a 95% chance you don't have a UTI if you have less than 5 white blood cells. But then I said, let's look at this further because this is a one-size-fits-all approach for 3,392 patients. I wanted to see what this looks like when we break this down by age. So looking at the NPV of leukocyte esterase and WBCs and nitrite by age. And as you can see, when you look at older women, consistently across the board, the negative predictive value is not good for any of these parameters that were good for the other populations. When you look at nitrite, it's not good for women in general, as well as older men. And so the population that this UA, the NPV of UA works really well is young, or I wouldn't say just young, but any male under 65 years of age. And pyuria works well in men in general, but not great in women. It may work well in younger women, but not older women. So unfortunately, older women, when we use a urine analysis, either for its positive predictive value or negative predictive value, we're not doing them justice because these data don't really apply to them. And so part of all this work has led me to take a step back and try to understand what is driving the inpatient clinician approach to management of UTIs and asymptomatic bacteriuria in older adults with and without dementia. A big part of this was I felt like we were all speaking a different language when we were rolling out interventions. And I first wanted to understand, what do people even know and what do they think and how do they practice? So there were some very interesting things that came up. And I'll be honest, I've only highlighted the interesting ones and not the ones that were straightforward, because I think that the interesting ones will be the ones where we can talk about. So this was a qualitative investigation that was just done in the past 6 months. I did semi-structured interviews of clinicians. I stopped at 15 because I felt like no new themes were emerging after that. And most of these were 20 to 25 minutes over Zoom. We had a good mix of sex, race, specialty, and level of training. And I tried to be as inclusive as possible, even in an environment where it was tough to bring in a lot of diversity. I was very conscious about making sure we have a diverse population that we interview. And then I wanted to share some of the things that I thought were interesting. So I asked people what asymptomatic bacteriuria means to you. And I didn't know that this is what the world outside of my little infectious disease aging thinks about. And so people said, when I think about this buzzword, it makes me think of pregnant patients. I primarily hear or see about it in pregnancy. I think of patients who might just be sort of chronically colonized. I've seen a lot of these folks that have had instrumentation. And I wasn't hearing anyone say an older adult or someone who is in a long-term care. And so I realized that because of our messaging around who to treat for asymptomatic bacteriuria, it looks like a lot of people believe that these are the only patients that have asymptomatic bacteriuria, and that bacteria in other people's urine, for example, an older adult, is a true UTI. And then I started to ask them, how do you diagnose a UTI in an older adult, say with dementia or delirium that cannot express symptoms in your practice setting? And this was where it was very revealing to me, because this was coming in from some of the emergency department interviewees, where they said that I would say that sometimes when we get imaging for someone, like a CT, and it shows bladder wall thickening, or enhancing fat stranding around the kidneys, that makes them think of a UTI. And this is, granted, someone they have not seen yet. This is someone who went to CT before they see them. And so that's what the next person said. Sometimes we're seeing a CT result before we see the patient. And then again, they're in elderly patients that are slightly altered, but we have a CT and all they have is bladder wall thickening. Everything is negative. It's possible that they still have a UTI. I would probably give antibiotics, believe they still have an indication for admission. I'll probably try to get them in. And this is, something to think about, is bladder wall thickening can be a normal finding in older adults. So I actually called up the radiology fellows and I said, what do you do when you have to read a CAT scan on someone that you have, that you comment this bladder wall thickening? What drives this kind of comment? Can you walk me through it? And the radiology fellows told me that there's no clinical notes on these patients. There's no history on these patients. So they report everything. And then they say correlate with urine analysis, which is a bummer because you see bladder wall thickening. There's a comment that says correlate with urine analysis. You order a urine analysis on the patient that is chronically colonized, has asymptomatic pyuria, and then you're driven to treat it based on what I'm hearing. And then the last part of it is like motivation. So I asked them, like, how do your colleagues approach this? How do you, do you perceive these patients as a team? And what I heard is in most cases, we always err on the side of starting IV antibiotics to be safe. There are some attendings that are like, oh, that's just a high number in terms of white cells. And this is the white cells in the urine. Maybe you should just treat them despite them not being symptomatic. And then for someone who's nonverbal or just kind of like can't articulate anything or is groaning, I can't do all that much besides hit them with antibiotics and admit them, especially if they're altered. So this is where people are coming from, and it's important to understand their barriers so we can help them. And so I asked them, what can you envision a tool that you think can help you in these specific patients? So specifically older adults that may be nonverbal because of dementia or delirium. And a lot of them told me that they would like some kind of a scoring system, something like they have for MI or for stroke, and that would help them better direct everyone to play right. They did want to do the right thing, just didn't know how to justify it in the chart. And so one of them just looked at me and said, maybe there could be some kind of a clinical decision support tool that you embed in Epic, like an MD Calc sort of thing. And that was helpful because that is what we've been thinking about specifically for, the patients that we discussed that are unclear, patients that have bacteriuria of unclear significance, or patients that have lower urinary tract symptoms. And that is where my future directions are currently focused. So like I mentioned, some of the most challenging scenarios for me are these patients in the middle. I am not sure what to do for patients with new onset or chronic LUTs. And sometimes these patients with LUTs or lower urinary tract symptoms may have asymptomatic bacteriuria on top of their LUTs, and then they keep getting treated and treated and treated. And then you have on this side bacteriuria of unclear significance, where you have a patient with delirium, fever, and a positive urine culture, and we don't know what that means or what to do with it because the patient cannot tell me that they have symptoms. And so there may be different approaches that we look at in the future. And this is something that I'm interested in working on specifically for patients with bacteriuria of unclear significance, is thinking about watchful waiting and optimization, something that has been recommended by Lona Modi in an article in JAMA, where she highlights kind of a stepwise approach and giving about 24 hours in hydration to cases that are not very sick or not in any kind of sepsis. And in some cases, we may have to treat them because we don't know. We don't know what is going on. So we just opt for a very short antibiotic course. And as soon as we have an alternative cause, we stop the antibiotic course. We choose oral options as opposed to IV. And we try to leverage the urine analysis for its negative predictive value. Also think about incorporating some of these urine analysis parameters in a calculator. So we're taking into account that it may not perform well in older women. And then think about reframing the risk. Is balancing the risk of treatment versus the risk of adverse events. And some of my prior data from Yale, I did look at reframing the risk a little bit. I followed patients that were treated for UTI appropriately and inappropriately, and found that in about 10% of the cases, there were some complications. Most of them were C. difficile colitis, but a reasonable number of them had a missed diagnosis. So specifically, one example there is had a patient that grew E. coli in the urine, and the team started to treat the E. coli and stopped following any of the other cultures and missed that the patient had Candida in the blood. And this is real. Like, this is a real story where stewardship pharmacist called the team and they said, no, the Candida is probably a contaminant. And we said, no, Candida in the blood is not a contaminant. The E. coli in the urine is a contaminant. And again, delay in diagnosis of infections. Like, one patient had an anastomotic leak that was delayed in its diagnosis, and some drug side effects. So there might be a way of balancing and showing people that your risk of UTI is 5%, but your risk of harm from UTI is over 50%. So at this point, it may be better to not treat. And some of the work that I'm doing with my colleague Valerie Vaughn is trying to look at the risk of bacteremia, because that's what we're scared about, is sepsis or bacteremia in patients with BUS. And we specifically wanted to highlight that patients with altered mental status or dementia without altered mental status or change in urine color or character, did not confer a significantly higher risk. I think in some combinations it might. So for example, if you had high pyuria as well as you had AMS or altered mental status and you had SIRS criteria, you likely may have an increased risk. And that is what we're working on for the future, is to see how can we combine different risk factors that are significant to come up with a personalized risk estimate. We use 2% as our personalized risk estimate. And what we showed by using that is, even if you used 2%, which is what the emergency department clinicians love, that's what they use for MI, you can still avoid unnecessary empiric therapy for UTI in 70% of these patients. And it is developed using this model here. So it's a combination of pyuria, SIRS criteria, your age, urinary retention, some other symptoms, and serum WBC. And this is not the first time this is done. So someone else has attempted to develop a UTI calculator in neonates, and this is used extensively in the ED. And so we will be modeling our calculator based on this calculator, because I think it's very helpful. So it first tells you, based on symptoms that you see on the left here, which they have some demographic and some symptom-related data, is whether you need to get a urine analysis. And then when you get a urine analysis and you plug in some numbers, it gives you the probability of UTI and tells you when to treat. Again, this is not a foolproof method, but it may be a method to reduce inappropriate prescribing in a large number of patients, close to at least 70%. And so I'll end by saying understanding why UTIs are overdiagnosed and why urine tests are misused is important to design the correct intervention. I love using the COM-B model when I'm designing or understanding interventions, specifically because there are unique barriers in older adults and people living with dementia when it comes to diagnosing UTIs. And as we develop interventions, I'm trying to focus on the specific drivers. So if the major barrier is motivation, then I'm trying to focus on influencing patients with some kind of a tool that gives them risk estimates for harm, rather than just focusing on education alone, which would be based on capability. And I'm currently focusing on bacteriuria of unclear significance with a goal to focus on LUTs in the future. I'd like to thank all my mentors and collaborators and the Pepper Center for all of the support and guidance. And I'll pause here for some questions.
Thank you so much. This is such a common problem and so difficult, and clearly such a need for what you're developing. Let's see if we have any questions in the chat, or if anyone wants to just raise their hand or unmute yourself, feel free.
Sarah, can you see me? It's Jeff.
Sorry, I probably went over to the other screen. Go right ahead, Jeff.
Yeah, so Sonali, thank you for the shout out. First up, that was, I'm like sort of listening. I was like, Julie Simsack. I was like, oh, I've written something with her, and
Yeah.
so thank you for the shout out. Um, Great talk, and you might have missed it in the chat. I put the head exploding emoji in
Yes, I did. I saw that.
the head exploding emoji. That I've never quite seen the performance characteristics of all the components of the UA presented quite that way, and so that was fantastic. So I will. And you said you presented that at ID Week, so you haven't published that yet?
I have not published it, but I'm waiting for my continuum of UTI manuscript to get accepted, which I'm hoping it gets accepted because then I can refer to the methods and then submit this one. It's ready. It's ready to go.
Yeah. Yeah, put it in. It'll get accepted. But I was going to say, like, yeah, would love to think about opportunities to collaborate because literally this morning, and actually I should point out that like we have a whole number. Looking at the names who are on the call. In addition to folks from the Pepper Center, I see a bunch of names from our Northwestern Medicine antimicrobial stewardship team. So this is clearly of interest. But I was going to say for a research project I'm on with Julie Simsack and Jeff Gerber from Penn, we're trying to look at high antibiotic utilizing patients, and so like literally just put in a data request today for all patients who received outpatient antibiotics or not actually at Northwestern Medicine. And we're gonna have urinalysis data for all of our outpatients, so it'll be strictly outpatient data. But so we'll have our hands in all of those data in pretty short order. So would
That's awesome.
love to think about collaborating.
Definitely.
Yeah, but great work. Thank you.
Yeah, thank you.
Justin, do you have a question or comment?
I do. Thank you so much, Sonali. This was incredible and very timely. Like Dr. Linder mentioned, there are a bunch of us from the stewardship team, and we're trying to really focus on ASB over the next few months. We're struggling to come up with the best multi-prong approach. I was wondering if you had any insight at what has worked at Duke, in terms of limiting UA and reflex urine cultures, or if there are nudges within the EHR. What from maybe the diagnostic and EHR standpoint have found to be most effective?
Great question. So I can talk about what's worked at Duke, but one of my first mentee actually is at Northwestern right now. I think she might be an attending already. Catherine Gao. She's a critical care. So we worked on a really big project at Yale. And there were two things that made that project very successful. Is I had a lot of internal medicine champions because Catherine actually was the champion, and she was helping me disseminate our urine culture algorithm and connect with all the residents and all the chief residents. So she was helping me connect with champions in other departments. She had strong connections with neurology as well. So that helped me is to get champions in different divisions and departments and have them, take forward the work. But honestly, the only thing that worked was that we created a human barrier to order inappropriate urine cultures, meaning you would have to call someone if you deviated from the algorithm. And that someone was me 24/7. And the beauty of that was at least 40% of inappropriate culture orders people did not want to call. And so they just did not order them. 30% would call and would fight about it, and I'd say fine, just because my goal was to reduce it, not to stop. And then 30% would have an actual discussion and learn from it. So it felt like that was a very meaningful intervention. It's not always possible, but creating any kind of a forced function where someone has to do something to be able to order the culture. So if they have to bypass something, a lot of people will just not do it if they weren't thinking about it so much.
We refer to that as not a nudge, but a sludge.
Right.
So we actually have a manuscript coming out.
Nice.
It'll be published in February for an intervention we did here for reducing. And Sarah, you're on that paper, yeah, with the Beagle trial.
No, I think that was Teresa still.
Okay, all right. But so it's the Beagle trial, one of three interventions, and one of them was to reduce ordering of UAs and for asymptomatic bacteriuria in outpatient, and it worked. But it involved things like a justification alert, was kind of the main thing.
Yeah.
So to be forthcoming, that is forthcoming.
Nice.
Great, thank you. Yeah, we're trying to implement it on the inpatient side, really to ask for those symptoms earlier, or if the patient meets that exception criteria. But like you pointed out, the things like, well, the patient's coming in altered, maybe they have some retention. That's where we run into more issues, because it could be, totally unrelated, but it's harder to justify in those specific situations.
On that note, I can share a personal story. So I went to our primary care here, and so I have to sigh, because I went in and I the only symptom that I had was I was having just a little bit of abdominal pain. And there could be many reasons for that. And I'm talking about this medically, but they ordered a urine analysis and a urine culture. And I have no urinary symptoms. And I was so devastated in that moment, because I was like, we've spent so much time educating here. We've spent so much time. But I said, all right, I want to see what happens next. So out of curiosity, I said, I'm going to go ahead. I'm not going to say anything. And I, again, wanted to see what happens once the culture is ordered. And I said, okay, somebody's going to teach me how to collect a midstream urine sample, right? And so nobody did anything. They gave me a sample cup and they said, go. And I said, well, this is interesting, because we've developed a whole educational program around collecting urine samples in our primary care. And they don't know who I am. So I just went by and, and now I'm waiting to see what the primary care physician will say to me. So it's kind of undercover for myself. But it's shocking. It's like we spend all this time. And so there's definitely something going on that we haven't been able to figure out. And maybe we need stronger barriers to ordering.
Other questions, comments?
I have a comment and a question. So my name is Iman Al-Nagar, and I'm a Rec Scholar at the University of Connecticut. And so I've also recently received the award from the AUA to start my first human clinical trial doing an intervention in older women with lower urinary tract symptoms. The reason I'm here today is because one of my exclusion criteria is a UTI, obviously. And I tried to learn a little bit more about, what will I define as a UTI, and not just go by the urine analysis that we're going to do, because, clearly, I have to say I have more questions than answers now. So I think I'll be reaching out to you by email to get a little bit more clarification. But I love that you're thinking about this in so much detail, because it's obviously a problem, and it will affect also how, we recruit for my research study and et cetera in older women with LUTs. So that's going to be, I think, a little bit of a challenge, but I'll reach out to you.
Yeah, it's going to be tough, because a lot of those women will have mixed flora in their urine, and they might have positive urine cultures. So it's going to be, it's tough.
Yeah. Thank you.
Yeah.
Great talk. Yeah.
Thank you.
Any last questions for our speaker or comments? I think there's a lot of interest in this, such a common topic, such a common issue. Thank you so much for sharing your work, and we're looking forward to hearing more from your next phase.
Thank you so much.
Thanks for everyone for joining us.
Bye.
We'll see you next month.